I really thank you, Ty, for the warm introduction. I'd really like to thank the planning committee, Brian and Susan and everybody else involved for having me here. As a perfusion educator, I'm just completely fascinated with the level of innovation that takes place at this conference. As Ty alluded to, the 320 people that are joining us via webcast, some of which I understand are international. So the beauty of that is we're making the world a smaller place in perfusion every day. So as an educator, I really enjoy that. The purpose of my lecture today is to, you'll hear the expression, I'll use it more than once, to steal shamelessly and share seamlessly. That there are a number of excellent things that are happening in our industry, some of which are being led by perfusionists, everyday perfusionists, doing extraordinary work outside of their clinical responsibilities. And so when I thought about this topic of optimizing value and perfusion quality, to me it was a fairly easy presentation to put together because we have all these great things happening in silos, but bringing it together to really define how a perfusionist fits in the role of hospital-based value and quality. We're a very, very small part of the continuum of care. And we're somewhat insulated in the operating room from the discussions that take place at the C-suite level about how we define quality and safety and value. They've trickled down to us, though, and so I thought this topic would be appropriate for us to identify and understand how perfusionists can contribute to the health value quotient. So I have no financial disclosures, but in thinking about this topic, I really thought about the words that we hear thrown around quite frequently. And oh, by the way, as we're asked to increase the delivery of care we provide, the value, we're doing it with less costs. And on top of that, we're doing it with less of a workforce because of the growing demand for perfusionists and the backfill that we have in terms of the number of available perfusionists in our workforce. But in order to know where we are in healthcare today, we kind of got to step back and know where we've came from. And interestingly enough, the idea of national health insurance isn't new. In fact, we're thinking about it now in terms of the shape that government should have in our healthcare system. It's being debated almost every day. You can't keep up with the direction that we're headed. I'm not sure anybody really knows what direction that we're headed. But this discussion actually took place 110 years ago. Of the idea in the Progressive Party, a Republican president, Theodore Roosevelt, proposing the idea of government health care insurance. Unfortunately, that never came to fruition, and then we ran into World War I, and at that time, there wasn't national health care coverage. But what did happen as a result of World War I is that now we have an unemployment rate that went from 7% down to 1% because everybody was either fighting off in the war or having to leave the household and work to keep the country moving. On the left-hand side, you see here a woman, an employee, with her little daughter next to her at an oyster shucking plant. And in fact, they would work these ungodly hours, these 16-hour shifts, and the kids, even at that age, would help out. But as more people entered the workforce, we also had more workplace injuries. And in order to ensure that the assembly lines kept running, business owners and employers came up with this idea of, if they're injured at the workplace, why don't we treat them there and put them right back to work? So they started engaging with local physician groups to offer care on site. And then this happened, the stock market crash of 1929. And as a result of that, hospital occupancy rates dropped pretty dramatically. So hospitals were in danger of going out of business. And so CEO of Baylor University at the time came up with this great idea. What if we went to the hospital and decided if we pay you 50 cents a month per employee, that you would provide our employees with health care coverage up to 3 weeks of hospital care? That became what we now know as employer-assisted health care insurance. And it started to become the model with lots of other employers because that was something that Baylor could market to educators in deciding whether or not to work for them or somewhere else. So a commission later was assembled to define how healthcare insurance would work across these geographic regions, and they came up with the Blue Cross Commission, which defined that these healthcare insurance companies can't compete with one another, can't steal business from one another, so you have now Blue Cross. Well, the American Medical Association felt like physicians were being pinched out from their relationships, so they said, well, we need a plan like that for physician care, so they came up with the Blue Shield plan, Blue Cross Blue Shield, and this is where we are today. And so two-thirds of all residents in the U.S. that are employed have health care insurance. But who did we leave behind? We left behind vulnerable populations, both those individuals that can't work by virtue of age and those that are unemployed. And so in 1965, we had the Social Security Amendment of 1965, which defined both Medicare and Medicaid. And then at that point, the government became the largest healthcare provider. Now, if you look at this slide here in terms of the solvency of these healthcare, this healthcare administration with Medicare, you can see here on the y-axis, pointer here, on the y-axis here you have the reporting year, and on the end of the bar graph represents the year that they estimate that the Medicare system will no longer be solvent, meaning that the expenses will exceed the income, and the trust fund will run out. So here you have a big change from 2017 to 2029. That was the inception of the Affordable Care Act, and it's kind of bounced around based on changes to our federal and state laws. But regardless of which aisle that you support, which side of the aisle you support in terms of what healthcare is going to look like in your country, this has to change. You can see 2026 now is the projection when we're going to run out of money to not be able to pay all the costs for Medicare. So despite what you think about the form in which it takes, something has to change. And really what it comes down to is quality, cost, and access. And there is no country, there is no government across the world that has all three of these figured out. So you may have good quality and access to everyone, but it's going to cost a lot. Or you may have access to everyone and good quality and high cost, but or low cost, but whether or not it's quality. So trying to find the proper ingredients across these is really important. There's this phenomenon called moral hazard. What's moral hazard? Moral hazard says, if you're paying for it, I want the best. So if I'm covered by healthcare insurance, I want top-notch healthcare. I want the white glove special. If I'm going to dinner with Tony tonight and he's buying, we're going to the steakhouse. I'm going to get the porterhouse. I'm going to order the Chateaubriand. Is that how we pronounce it? And I'm going to get the creme brulee and perhaps a Remy Martin at the end. Now, if he tells me I'm buying, we're going to go down to the bar and I'm going to get the grilled grouper sandwich. We're going to split dessert, and he's not allowed any alcoholic beverages. So the most interesting social experiment that ever took place was called the Rand Healthcare Insurance Experiment. And they assigned 7,500 families with different responsibilities in terms of cost sharing. So they paid different level deductibles. What they found was that as the amount of expenses was incurred onto the families, that they didn't get as much health care. So some of the unnecessary spending went away. Unfortunately, at the same time, what also happened is some of the things that they really should be getting also went away, a 30% reduction on what they need. So we couldn't put the burden solely on patients and patients paying for it. So what CMS decided to do, and being supported by other private healthcare insurance entities, is come up with a risk model where hospitals would incur some of these cost-sharing expenses. So, for example, you hear about things such as pay for performance and bundle payments and accountable care organizations, ACOs. These are helping to offset some of the risks and the costs between the healthcare insurance provider and the institution. And currently there are, I believe, 516 ACOs, and these ACOs are designed to ensure that, yes, patients will get the care that they need, but hospitals can benefit if they keep patients, if they keep engaging in preventative measures and keep them out of the hospital. Hospitals do better. And so now you're seeing this shift from volume-based care to value-based care. And what's interesting is that the value is in the eye of the beholder. So there are some measures which indicate that perhaps these pay-for-performance models don't quite do exactly what they were intended to, but the theme here is that it is shifting. And it's almost like the boat coming away from the dock, that hospitals now are starting to stand with both feet, and they're going to have to make a decision whether or not to stay on the dock or get off onto the boat, and you're going to see more of that coming forward. So let's talk and transition into quality now. What is quality? When do you know quality when you see it? To use a crude analogy, I know what pornography is. I can't describe it, but if you show it to me, I can probably say that's what it is. So what does quality look like, and is it subjective? The Institute of Medicine, which is now called the National Academy of Medicine, defines quality as the degree to which health services for individuals and populations increase the likelihood of desired outcomes and are consistent with current professional practice. That's a mouthful. But they go on to define what the ingredients are of quality care. And you can see the 6 major ingredients that are on the left-hand side of the slide here, from patient safety. Are we keeping patients from harm? Is it effective, meaning that is it based on sound scientific evidence? Is it efficient? Money is unnecessary spending is waste. Is it patient-centered? Is it focused on what's the best interest of the patient? Is it timely? Wasting time is waste. And is it equitable? And Arvidas Dhanabedian, who some consider to be the father of quality, went on to define the essential pillars of quality framework. The structure could be things such as, the equipment that you use, the staff that you have, the alarms and features and framework that you have, the things you can touch and feel. The process is how you go and do things. And then the outcome. As Mama always used to say, the proof is in the pudding. Do your outcomes, are your outcomes what you desire to be, and does it affect positively patient outcomes? So this happens. Quality is measured across your health system, across departments, across regions, across states, and across the country. So when I think about it for perfusion, there's the structure, which would be the facility, the devices that you use, and whether or not you have enough staff that are capable and qualified to do the services that are provided. The process, which could be things for you such as standards and guidelines, clinical practice guidelines, which are evidence-based, and outcomes, quality reports, and participation in registries, some of which I'll show you today. So I want to use this document as the framework, as the skeleton for the rest of my talk. And this is the most recent standards and guidelines that were approved by the membership of AMSECT in 2017. There are 18 standards now, each of which have certain things that we would define as a standard, which are things you really should be doing, and guidelines, which are more recommendations that are a little bit more loosely based. And you can see here, this is for adult cardiopulmonary bypass, and most of the domains, at least from general adult cardiac surgical perfusion practice, have been identified. And subsequently, these were endorsed by the AATS, the American Association for Thoracic Surgery. So even your surgeons, the largest surgical organization that we have in cardiac surgery, have at least endorsed these guidelines. And again, I'm stealing shamelessly here. This is from Bob Groom, and Bob Groom went ahead and presented this a couple years ago, looking at how we could use the standards and guidelines to fit it into those pillars of quality care, both from the structure standpoint, the process, and the outcome. So this is going to be what I use to move on to the agenda for the next set of slides here. So the Joint Commission has a booklet, a document on patient safety. And this particular standard here, Joint Commission Standard 040405, explicitly describes safety, not only safety, but proactive risk assessment, that we define what the unsafe things are before they actually happen. And as an institution, you should be engaged in proactive risk assessment. So there's the root cause analysis, which most of you are familiar with. An accident has happened. We need to figure out what the contributing causes were that led to that accident so we can learn from it. But is there anything you can do to prevent the accident from happening in the beginning and learn from potential mistakes? And so you can see I've outlined a few of those here. So one of the best tools that perhaps our industry currently has available is called a failure mode and effect analysis. And it's just that. It's a way to quantitatively score things that happen in your practice every day. And these aren't just things related to the equipment that you use. It could be personnel based. It could be based on your process, your clinical practice. It could be based on even things such as the non-technical skills, how we communicate with one another, how we work collaboratively with one another, and then how we measure our outcomes. So it asks the questions such as, what could possibly go wrong? Why would it happen? And what are the consequences of each of these failures? And so you can see the difference here between how we do proactive versus reactive risk assessment. In reactive risk assessment, the accident's already occurred. The patient potentially has already sustained an injury. What can we do to prevent that from happening? Could we have potentially mitigated that risk by doing a proactive risk assessment? And this actually isn't my work. This is the life work of Gary Grist. Those of you that know Gary is retired. He was a perfusionist at Mercy Children's Hospital in Kansas City. And you've seen the perf list post. Gary has dedicated a large portion of his time and energy into developing these templates for you, the perfusion community. And he's had the help of a number of different volunteers. There are 58 adult failure mode effect analyses templates available on the AMSEC website that are easily accessible by anyone. And you could actually pull some of these down and use it as the skeleton for delivering something on your own. But this is an example of what Gary used, and in this particular case, we're looking at a roller pump that fails to turn. So if you have an arterial roller pump at your facility, what would you do? The failure mode would be, what happens if it failed to turn? So you can see the potential effects of the failure, the bad things that can occur to the patient, the causes of why it would fail, and then the preemptive management. Okay, it's failing or it's going to fail. What would you do? Do you have a protocol in order to ensure that everyone on your team knows what to do? Remember, a chain is only strong as its weakest link. The majority of your team may know what to do, but does everybody on your team know what to do and can do it efficiently? So you scale these. This is the risk priority number. And you scale these based on how harmful it is from 1 to 5. You scale it based on its occurrence, how often does it occur, how easily is it detected, and then the frequency is who's involved. Is it just adult patients? Is it adults and peds? Is it a mixture of both? And you multiply all these numbers together and you come up with a risk priority number. And that risk priority number serves as a template now. And as you think about these failures and decide what you can do to fix them, you actually could use this as a quality improvement initiative. So when the Joint Commission comes and finds us, and they find us now because of things like ECMO and VADS, they know we exist, and they come to your department and say, tell me, what quality improvement initiatives has your team conducted this year? This is a perfect opportunity to say, we've significantly reduced our risk by looking at how we practice and just instituting whether or not it's more safety features or a second check by a perfusionist or slightly changing your circuit design, how you can drive improvements in both the quality and safety of the patients you deliver. And again, these templates are available for you, 58 of them. In fact, Gary's now working on ECMO. I can't even catch up with him. He's now on his 7th failure mode for ECMO support, which really is a nice dovetail to our discussion from yesterday about simulation. And these are some of the strategies that could come as a byproduct of failure mode effect analysis. Even having a standby tank in the room if you lose your gas source. Or Bob Groom and his folks at Maine Medical came up with a bridge around their oxygenator. So if their oxygenator fails, the Pronto line, parallel replacement of a failing oxygenator, that they can do it without coming off bypass support. Even backup personnel. We're all being asked now to cover more standby cases, lots of TAVRs, bring back bleeders, lead extractions, mitral clips, even doing flybys on ECMO staffing. It's really starting to stretch our team. Do we have the staff to be able to do that safely? And then crisis management drills. This is an example of a potential crisis management drill that Bruce Searles provided to me. I'll let you run this here. here you have a failing centrifugal head. This is the biopump hand crank. See a problem here? So, how often do we try to minimize the tubing lengths of our circuit in order to decrease our net prime? Do you actually go back and check some of your crisis management drills to ensure that you can still do what you think you can do in an emergency? This slide I borrowed from the AMSEC website. Those of you that have seen, they have a number of polls, online polls that are available. And in this particular one, the question was asked, when was the last time your perfusion team scheduled a mandatory practice of an emergency protocol? You can see 39, so there were only 135 total votes, but if you look at the proportion here, at least almost half of the individuals had gone longer than a year that responded, or don't do any practice emergency drills in any capacity with their team. So this is an opportunity for improvement. The process could be things such as evidence-based guidelines. This is the 2011 Ferraris guidelines everybody's familiar with. This happens to be the most cited publication in the Annals of Thoracic Surgery, the #1 cited article. And perfusionists have become involved in writing clinical practice guidelines for things such as inflammatory response, temperature management, most recently with anticoagulation. The renal guidelines are available. In fact, there is a group of individuals working on the 3rd iteration as we speak on the blood conservation guidelines. So those are available. And I think Jeff is probably going to touch on this in his lecture a little later, but we can come up with these guidelines and have them published across all of our journals, but whether or not they're actually adopted is another story. So after the 2007 STS Ferraris guidelines, this survey was conducted across perfusionists and anesthesiologists. So when they asked the question, not more than 3 years later, did you have a formal discussion about these guidelines with your group? You can see only about 20 to 25% of perfusionists and anesthesiologists actually had the discussion at their institution. And whether or not they actually made changes to their clinical practice, once again, was about 25%. So there's opportunities for us to help disseminate these guidelines at the local level, but perhaps we need to write them in a way in which they're more actionable. So I think we're all kind of learning in this process, but you're going to see more of these documents become published and available. Getting back to the professional standards and guidelines that you see here, again, here's some of the definitions that were used to define some of these recommendations, whether or not they were standards that we really think you should be doing, and then guidelines, things that you should probably consider. This was voted on and approved by the AMSEC membership, and supported by lots of literature. So you can see all the regulatory agencies that were referenced in these practice guidelines. And the #1 standard is, standard 1 is development of an institutionally based protocol. So does everybody know what their roles are, how to do them, and could we institute these protocols across your department, across your team, to not only help reduce the level of improve standardization, but also help them facilitate ways to not only improve the teaching of new employees that come in and keep teaching people that evolve through the system, but also as ways to try to contain costs because of unwanted variability. And there are a number of different resources that you could use to help create protocols of your own. By show of hands, how many people have institutional protocols at their center that they use? Okay, so probably about half or so. This is a real opportunity, especially if you're either in a large group or even if you're covering multiple hospitals. Does everybody understand and operate the same way? Could we, yes, there always is going to be an opportunity to work outside of the standards and the protocol if you feel like it's in the best interest of the patient, but the majority of the time, we should all be trying to conduct bypass the same way, at least within your institution. So if a patient comes into an operating room, it wouldn't be dependent on who the perfusionist is, whether or not they get good care on bypass. And this is the National Health System's tool, which is available online for developing your protocol, starting with prioritizing what your topic is. Perhaps there's a few members of your team that want to participate in this, come up with some objectives, gather information, pilot the protocol, and probably one of the most important things after you that you pilot it is you monitor variation and review the performance of the protocol. And again, there's some great work going on now. This is from Shauna Bronson. Shauna is a member of the ICEBP committee as well as the safety committee, and her and several members of her workforce are actually creating templates for you and for us. Generalized templates that could be taken as a protocol, and they need to be customized to your facility, but giving you the tools that you would need in order to generate your own protocols. Her and her committee are starting with some more detailed protocols, or protocols that don't happen as often. They're not as general as routine cardiopulmonary bypass or cardioplegia administration. She's working on things such as HIT, pregnancy and bypass, pregnancy and bypass, and so she is really passionate about this, and she's intent on sharing these with the broader community. So you don't have to create these things from scratch if you don't have to. And I only pulled in the interest of time, I only pulled one other standard, which is Standard 14, which is something that we discuss at meetings all the time, is that we're being asked to do more with less in a shortened and a staff-depleted workforce. So those programs that are Perfusion is being asked to cover TAVRs or mitral clips or cath lab-based interventions, pacing lead extractions. How many perfusionists does it take to cover all the services that you need in order to make sure that you have backup in case one of these rooms goes down? Yes, the majority of the time pacing lead extractions go great, but what happens that one time where it doesn't? Do you have the staff in order to cover all of these services without burning out your current staffing situation? This is just a depiction of where we've come in just a few years with TAVRs. So perfusionists are finding themselves spending far more time in the cath lab than they ever used to. And here's a few standards on what we think are important in terms of maintaining staff for cases that may not necessarily need bypass, but could potentially. Do you have a protocol which helps identify how you identify those cases? Here, once again, we haven't just stopped at adults. In fact, there are current standards and guidelines for mechanical circulatory support, and then there are proposed guidelines currently being reviewed about pediatric and congenital practice. And so I think, in my opinion, one of the greatest responsibilities of a professional organization is to develop standards and guidelines that are endorsed by the membership and voted on and approved by the membership. And then lastly, outcomes reporting. So it's important for you to know you can have the structure and process, but does it translate into positive outcomes? And so there are two really important bullet points here with how do we ensure we're providing quality of care, and can we share, at least in aggregate, our results with others and learn from other people at the same time. So the Australian New Zealand College of Perfusion actually has been kind of the moral compass in this. They've been working on quality improvement for many years across their registry. This is at a local level. This is Rob Baker and Richard Newland at Flinders University, and they record a number of continuous values on bypass through their electronic medical record system. And so they did their own quality improvement study, looking at how that information is shared and can they improve outcomes. So they broke in this study of 900, almost 1,000 patients into 3 participant cohorts across their team. So in the one case, they recorded all the data, but they didn't provide any feedback to their employees. And group 2, they provided the information, and then they had some group discussion. Or the middle group here, which they provided the QI reports but no discussion, and then lastly QI reports with group feedback. And what you see here is, if you look at the confidence intervals here, you can see a reduction in variation just by doing nothing more than giving people information and having the discussion. So it's helping to drive quality improvement at the local level. And as I said before, they're doing this at the regional level across 2 countries. And here you could see, this is your x-axis here represents centers, so they're de-identified. Here's one of the metrics they look at is blood glucose concentrations on bypass, and then cumulative time with an arterial blood temperature greater than 37 degrees. You can see the box and whisker plots, which represents the 25th and 75th percentile with the line, the median in the middle. And you can see there's quite a bit of variation around centers. But now if you have the opportunity to share this information with other centers and say, what is it that you're doing to have really good outcomes here? What can we learn from some of those centers that are higher performers? There's a saying in Charleston in the Low Country that a rising tide raises all ships. And if we can work collectively together, we can improve care across the entire region. And then we have a stake in this here in the U.S. This is the Perform Registry, which has now partnership with AMSECT. And this started as a state quality improvement initiative in the state of Michigan across 33 centers. You can see the number of cases that were accumulated and the number of sites that participate. There are now 44 sites participating, and they too have the ability to benchmark. So you can see things here such as highest intraoperative glucose, looking at acute kidney injury, which was mentioned earlier today. I'd love to be operated on if I needed it at center 37 versus center 42 there, because you can see a pretty significant variance in terms of the frequency of AKI. So what is it about Center 37, what are they doing, and could they potentially share their findings with these other centers to help improve outcome across the consortium? And so it's quite fascinating. I've been to the Michigan quality meeting before. They meet every quarter, and before they go into the room, they sign a disclosure agreement, and they identify all the centers, and they use this as regional state collaborative opportunities for quality improvement. And it's fantastic work that they do. But again, this is the value of having the data, of knowing what your outcomes are and then benchmarking them against other sites. This is commercially available to all of us. So the Perform Registry is available to all sites. Tony Shackelford, a chief at MUSC, has us participating in it. We participate in a center I used to work at. We see real value here in giving that information back to our key stakeholders, not just perfusionists, but surgeons. So lastly, to summarize, how do we improve quality? Well, we have evidence, right? We have clinical practice guidelines. We have registry data. And hopefully, if we group those together, along with your experiences, because you're very good at what you do, we can help create the best care possible. And it doesn't have to be monumental changes. This is compliments of one of my colleagues at MUSC. His name is Ken Ingersoll. He's an active cyclist, and I'd seen this slide he presented a couple years ago, and I've borrowed it. There's a cyclist captain. He's a coach. His name's Dave Brailsford, and he was the coach of the United Kingdom cycling team, and they were never very good at the Olympic level. But once he took over as coach, they won gold. I believe it was 2004, 2008. I don't follow cycling. And they asked him, what was your secret to success? And he said, this aggregation of marginal gains, just making little changes over time, because change is the one thing people fear the most. So if you make small changes, for example, he let his cyclists, when they traveled, pick their own pillows so they felt a little bit more comfortable when they slept. Or when they put all the bikes in the trucks to be shipped, they made sure it was completely dust-free, because if there's a little bit of dust that gets between the brakes, it might affect performance just a touch. Or that they disinfected their hands. They had a doctor come in, a physician, and show them how to wash their hands so they don't get sick and infected. These little changes over time start to build into really wonderful opportunities. But conversely, if you're not always trying to improve your practice, you may fall on the other side of this axis, which is more riskier behavior, decreases in the value that you serve. So with that said, I really appreciate the opportunity to present it to you today, and I think we have some time for questions. I didn't use all of it, so thank you so much.